So, good morning, good afternoon, good evening, good night to all of you. I saw that we have attendees from all around the world today. First of all, I'd like to thank you for your time, of course, and welcome you to our FrieslandCampina Institute webinar about lactose intolerance, insights, and management strategies. My name is Jan Geurts. I'm a principal scientist in the expert team nutrition of FrieslandCampina, and I'm located in Wageningen in the Netherlands. I'll be your moderator for today. First of all, I'd like to thank my colleagues Daphne van Maris, Jocelyn Negou, Francis Riekhoff, and Erika Lier, all from the FrieslandCampina Institute who helped to organize this webinar. So today's webinar will focus on lactose and lactose intolerance, and we have an exciting presentation planned for you. Our speaker will be Professor Miranda Lomer, and she will talk to us about the mechanisms of lactose digestion, lactose malabsorption, and lactose intolerance, including prevalence, diagnostic methods, and symptoms. She will also discuss strategies for dietary management of lactose intolerance and touch upon some of the misconceptions around this topic. But before we start, I would like to share some practical information with you. This webinar will be recorded, and the recorded will be shared with you afterwards. During the webinar, you can write your questions in the Q&A section, which is located at the top right corner of your screen. Please note that there is the possibility to like questions that you find particularly interesting or relevant or important. Please do not forget to fill out the evaluation form that will be shared after this webinar to receive your attendance or certificate or accreditation. And specifically for Dutch healthcare professionals, accreditation is in progress with the organizations listed on this slide. Before I am going to introduce Dr. Lomer, we would like to show you a brand new movie about the FrieslandCampina Institute that briefly highlights what the Institute is about and what it does.
Everyone around the world, at every stage of life, deserves adequate nutrition to live healthily. FrieslandCampina Institute is an engagement platform for healthcare professionals dedicated to improve global nutrition status by sharing scientific knowledge on the role of dairy in healthy and sustainable diets. FrieslandCampina Institute was established over 20 years ago. Today, we annually connect with over 3 million healthcare professionals worldwide. Throughout science-based articles, learning programs, educational tools and resources, we deliver accessible and applicable dairy science to healthcare professionals. We uphold the highest standards of quality and credibility by partnering with leading experts, professional associations, and healthcare providers. Are you a healthcare professional and you want to know more about dairy, nutrition, and health? Visit FrieslandCampinaInstitute.com or subscribe to our newsletter.
Wonderful. And with that, I take great pleasure in introducing Professor Miranda Lomer, who is a senior consultant dietitian in gastroenterology at Guy's and St. Thomas's Hospitals in London, and who also has an adjunct appointment as Professor of Dietetics in Gastroenterology at King's College London. Her research interests include the nutritional management of functional bowel disorders like gastroesophageal reflux disease and irritable bowel syndrome, as well as inflammatory bowel diseases like Crohn's disease, ulcerative colitis, and orofacial granulomatosis. She has research skills in dietary assessment and nutritional management of these conditions, and has vast expertise in conducting national audits, developing national guidelines, and conducting multi-center clinical trials. Professor Lomer is editor of a book entitled Advanced Nutrition and Dietetics in Gastroenterology. She gave the BDA Elsie Widdowson Lecture in 2014 as recognition of her international impact in dietetics. In 2016, she was awarded an MBE for services to dietetics and gastroenterology. Dr. Lomer, you have the floor.
Technical problems, and hopefully there won't be any more. So I'm going to, these are my conflicts of interest. And Jan very nicely introduced the topic, so I'm not going to hold on this slide, but just to show you that this is my view from St Thomas's overlooking the River Thames. It's a wonderful place to be, so please do come and visit London. So let's get started. So lactose is a natural milk sugar. It's the only milk sugar, and it's composed of glucose and galactose. And it's a disaccharide exclusively present in mammalian milk, and it's a major component of milk. It's the main carbohydrate of milk. Lactose is also used in the food industry and the pharmaceutical industry as a sweetener, a taste enhancer, a filling agent, a gel former, a stabilizer, coloring agent. It has structural properties and can be used as a preservative as well. So it has lots of different functions, but the main function that we find is that it is providing us with carbohydrate energy. Now, milk is a unique feature of mammals, and it's only in mammals that we find milk. And galactose and glucose are present in almost all mammalian milks, but not always in the form of lactose. And if we look at the different contents of lactose, you can see that a seal has a very low lactose content. It has a much higher fat content. And the human down at the bottom here has the highest level of lactose with 7.5% as lactose. In terms of lactose itself, as I mentioned, it is a disaccharide composed of glucose and galactose, and this is joined by a glycosidic bond, a beta-1,4 glycosidic bond, and this is an important component when we think about lactose digestion. Lactose is broken down by the enzyme lactase fluorescein hydrolase, or better known as lactase, and this occurs in the small intestine, in the brush border of the enterocytes. Its expression is mostly within the jejunum in the small intestine, and lactase is an enzyme that is really, really important in those first weeks of life while we're feeding from our mother breast milk. It's really important to think about that the expression of lactase is key to lactose absorption. And if lactase is expressed at 50% of its activity level, then that is sufficient for adequate lactose absorption. In terms of that whole absorption process, lactase, as I said, breaks down the lactose, and this occurs on the apical surface of the brush border, mostly in the jejunum. And you can see here that the lactase is able to attach the bond and break down lactose to galactose and glucose, and the absorption process then starts through the enterocyte with these transporters, SGLT1 into the enterocyte and GLUT2 out into the bloodstream for both glucose and galactose. Lactase production decreases after weaning, and this is an ancestral trait for most people. What's really interesting is that the majority of humans, about 65%, experience a 90 to 95% decrease in lactase production in the years after weaning. And this is what we call lactase non-persistence. Lactase persistence, on the other hand, is a mutation, and that occurs in some people who have had that mutation in the gene. Lactose non-persistent individuals become what we call lactose malabsorbers, and some can suffer lactose intolerance, and this is where you get symptoms of lactose not being absorbed. People with lactose persistence may also become malabsorbers, and they can also express lactose intolerance as well. In terms of the variation across the world, the age at which lactase is downregulated does vary, but it tends to happen soon after weaning. And there have been lots of different studies across the world looking at the age where this downregulation happens. And this, is an important consideration if we're thinking about lactose in the diet beyond weaning. In terms of lactose malabsorption, so this is where we find the presence of lactose within the lower part of the gut. You can see that the countries that have more of a red colour are where we have a lot of lactose malabsorption, and the countries that are sort of heading towards this sort of greeny and then dark blue are where we get very low levels of lactose malabsorption. So it's predominantly in Northern Europe and some parts of Africa as well. In terms of lactose intolerance, again, this follows a pattern where a lot of Africa and Asia has very high levels of lactose intolerance, as does South America, and the Northern European and the USA tend to have lower levels of lactose intolerance. So I mentioned earlier about 65% of people have lactase non-persistence, which means that about 35% continually produce lactase throughout their lifetime. And for some people, this might occur for the rest of their life, or for other people, it might reduce down over time, and particularly in later life. So lactase non-persistence is not just one type. There is congenital lactase deficiency, which is extremely rare, and primary lactase deficiency is the one that affects this sort of large proportion of the population. I said 65, it's sort of 70% of the population in this particular slide. It ranges from about 5% in the British population to up to 90% in the Asian population. And it occurs very frequently in individuals with irritable bowel syndrome, and I'll talk about irritable bowel syndrome and the overlap a little bit later. And what's interesting is not all people with lactase non-persistence develop lactose intolerance. And hopefully by the end of this webinar, you'll get an understanding of why that might actually be. You can also develop secondary lactase deficiency. So this happens in people with lactase persistence, but they get a temporary reduction in their lactase production. So that might be due to celiac disease or gastroenteritis. So the two definitions, lactose malabsorption is the incomplete hydrolysis of lactose and the presence of unabsorbed lactose in the colonic lumen. But lactose intolerance is the occurrence of GI symptoms due to unabsorbed lactose in the colonic lumen, and it's dependent on self-reported symptoms after lactose ingestion. So lactose malabsorption is really something that you can measure quite objectively, but lactose intolerance is something that's very subjective. So the pathophysiology of lactose intolerance, if we look at the normal lactose digestion, as lactose passes through the small intestine, it gets broken down by lactase, the enzyme, and the glucose and galactose get absorbed into the bloodstream. In lactose intolerance, however, there's no lactase to break down that lactose. And this means that the lactose continues further down into the lower part of the gut, where it gets fermented by the colonic microbiota, and that leads to gas production and causes symptoms and other things as well. In terms of measuring lactose malabsorption, there are a number of different types of tests that might be used. The one that is used most frequently in clinical practice would be the breath hydrogen test, and I will just explain a little bit more about that. So this is where we measure the amount of gases that are in the breath after ingestion of a test sugar solution. And this test sugar solution in this case is lactose, and the lactose gets taken up, it passes through the small intestine. If it doesn't get broken down by the lactase, then the resulting gases that are produced in the large intestine will be absorbed into the bloodstream, and then they're exhaled. And this is the gas that we're measuring. It's predominantly hydrogen, but for some people we also measure methane as well, which can be exhaled. So in terms of the test itself, there is huge variation in what might contribute to a breath test. And predominantly, we try to standardize these across the world, where you would have no antibiotics or prebiotics for 4 weeks, no bowel preparation for 4 weeks, no laxatives or antidiarrheal medication for 3 days, avoidance of test sugars, so things that would be fermented in the lower gut, for at least 24 hours. And usually it follows an overnight fast of 10 hours. People should have no chewing gum or smoking before the test as well. In terms of the breath test itself, a sample is taken at baseline, and then the liquid, in this case lactose, is consumed, and it would usually be somewhere between sort of 25 to 50 grams in 250 mils of fluid. And then breath samples are taken every 15 to 30 minutes for 3 or 4 hours. And symptoms are recorded during this whole process, and the gases are measured, as I mentioned, hydrogen and methane. But these tests do have false positives and false negatives. If you think about the large dose of lactose that's being taken in, this is not something that we would normally have in the diet in isolation after a 10-hour fast. So it could be that you're getting false readings from that. If you're getting a lot of lactose passing through the gut very quickly, it might lead to that bacterial fermentation. And you're getting those gases when actually someone in a normal situation doesn't really develop those sorts of symptoms and issues. The gases are absorbed into the bloodstream and then carried to the lungs. Sometimes what we can also see is that we might have small intestinal bacterial overgrowth, or SIBO, and that can interfere with the interpretation of the test results, because the bacteria in the small intestine are fermenting the lactose higher up in the gut, and therefore leading to gas production. And it's not actually happening within the colonic lumen. If it's happening within the small intestine, it may be that there is lactase there, but it's not having enough time, because the bacterial fermentation is leading to the gas production. So these tests are not always 100% conclusive. And it's important to confirm a diagnosis of lactose intolerance by going through the sort of the dietary plan, or what I would call the gold standard, which is where we would exclude dietary lactose until symptom resolution. And then we would re-challenge with lactose to induce symptoms and reintroduce lactose to a personal tolerance level. So in terms of the management of lactose intolerance, we would only suggest that it's restricted where it's absolutely necessary, and exclude it for 4 weeks in the first instance, and monitor symptoms. We'd then reintroduce lactose to tolerance, increasing by 1 gram per day, and adjust the dose gradually over time. What's really important to remember is that calcium is still well absorbed from milk, despite people having lactose intolerance. It's often that we need to be balancing symptoms in relation to the quantity of lactose in the diet. So dietary sources, so I mentioned at the beginning, it's naturally occurring in mammalian milk products. Commercially added lactose, it might be used as a bulking agent, fillers in pharmaceuticals, and it increases browning in baked goods. The average intake of lactose varies between countries. In Sweden, it's around 12 grams per day, and in the UK, we've measured it to be around 7. In terms of sources, so predominantly we're talking about the dairy products in the diet. So a 250 ml glass of milk would contain about 15 grams of lactose. A yogurt of 200 grams should probably contain about 8 grams of lactose. What's interesting with yogurt is the more time yogurt's left, the more of the lactose gets converted to lactic acid. So this is variable depending on the type of yogurt. Greek yogurt tends to be lower in lactose than other yogurts. And then there are these other dairy foods that also have a certain amount of lactose. In terms of cheese, if cheese is made using a sort of a long maturation process, like things like cheddar, brie, Stilton, Edam, feta, these have very low levels of lactose. Because the lactose has been converted to lactic acid. Also, because of the high fat content, butter, cream and cream cheese often only have a very low level of lactose, and it's really negligible, and people don't need to avoid these at all. In terms of the different types of milk, so if we look at cow's milk, the top 5 ones are all cow's milk, but depending on what type of milk it is, will depend on the level of lactose. So if you look at dried skim milk, which you might see in various products, it's a really high concentrated source of lactose. Whereas if you take semi-skimmed or whole milk, it's around sort of 4.6 to 4.7 grams per 100 grams. And if we look, some people often think that goat's milk is much lower in lactose. It's not really that much lower. So if people are getting benefit, it might be from a placebo effect, thinking that goat's milk is lower in lactose. So what about suitable foods? If people do have lactose malabsorption, where are they going to get those other nutrients? So milk and milk products, usually people can tolerate up to 4 grams of lactose at each sitting, even when they have lactose intolerance. And I'll explain a little bit more of that in a moment. You can use alternative plant-based drinks, and lactose-free milk is normal milk where you have had lactase added to break down the glucose and galactose. Break down the lactose to glucose and galactose. And then the plant-based alternatives, things like soya, rice, oat, nut milks, hemp, coconut, quinoa. There are all sorts of different plant-based milks available these days. I do recommend that if people are going to choose these, that they choose ones that have been, they have got added calcium and vitamin D, but sometimes these don't have sufficient levels, and we don't know about the bioavailability of some of these supplemented forms either. In terms of lactose tolerance, people can tolerate a different level of lactose, so usually up to 250 mils of milk per day if it's spread over the day. It does depend on the residual lactase activity. So I mentioned earlier that only 50% of lactase activity is needed to be able to tolerate lactose in a normal sort of quantity. There's no evidence that we develop small intestinal adaptation over time, i.e. there's no evidence to suggest that lactase production is going to increase by having lactose in the diet. However, the intestinal microbiota is really important, and I'll come on to that in a minute. Transit time is also important. So if you have a fast transit time and lactose is passing through the small intestine very quickly and doesn't have time to get digested by lactase, then you may get issues with lactose tolerance. Probiotics may also help to improve the tolerance, and lactose itself can act as a prebiotic fiber, and I'll talk about that in a minute. Also, we need to think about individual perceptions of symptoms. So this will vary from one person to the next and can be very subjective. Mixed meals can also improve the tolerance to lactose. So if you think about stomach emptying and how fiber and the contents of the stomach will help to delay stomach emptying. If stomach emptying is being slowed down, then the release of that lactose into the small intestine may be slower and maybe better tolerated. Supplemental lactase is a possibility for some people. It's not something I would routinely suggest, and it's not always effective. Food temperature may also affect transit and tolerance, so very hot and very cold foods can affect the speed at which things pass through the gut. So other considerations, so it's important to make sure that if someone is avoiding lactose-containing foods, that they're getting sufficient amounts of calcium and vitamin D. There's often bone mineral density issues that we need to be aware of or to be concerned about. Dairy-free alternatives may be supplemented, but they're often more expensive and they may have less bioavailability in terms of calcium. The reintroduction and compliance of taking foods containing lactose is quite key as well. And, we need to think about making sure that the diet is nutritionally complete if people are not consuming lactose. Many people with lactose intolerance don't have lactose malabsorption. So it may be that we just need to adjust the levels of lactose so that they can tolerate it better in their diet. Or perhaps it's due to something else. Maybe there are other fermentable carbohydrates that people don't tolerate, and actually they're thinking that it's lactose when it's not. There's a big overlap with symptoms in relation to irritable bowel syndrome, and I'll come on to that in just a second. And in terms of that prebiotic effect, we'll talk about that too. So in terms of lactose intolerance symptoms, things like abdominal pain, bloating, flatus, diarrhea, bulgurigmy, or noises in the tummy, nausea, vomiting sometimes, and constipation can all be signs. And there's a huge overlap with irritable bowel syndrome. In the diagnostic criteria for irritable bowel syndrome, you have to have recurrent abdominal pain on average at least 1 day per week in the last 3 months, associated with 2 or more of the following criteria: related to defecation or associated with a change in frequency of stool, associated with a change in the form of stool. And this has come from the most recent Rome criteria called Rome 4. And you can see that there is overlap here with the symptoms of lactose intolerance. In terms of dietary triggers for IBS, up to 90% of people report that food does induce symptoms, and 2/3 of patients restrict their diet in some way. 45% of IBS patients have lactose intolerance, and diet is the mainstay of treatment strategies. This is taken from the BDA guidelines. This is an algorithm where we use first-line advice for IBS, where we sort of check diet and lifestyle, check for food intolerances, especially milk and lactose, and then we assess dietary fiber, fluid, fatty food, caffeine, spicy food, and alcohol intake. And if this doesn't work, then we move on to second-line advice, which is the low FODMAP diet. The low FODMAP diet is where we avoid fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. The oligosaccharides, things like fructans from wheat, onion, and garlic, galacto-oligosaccharides from beans and pulses. The lactose we've been talking about. Fructose is from high fructose containing fruit or fruit juices, and the polyols are things like sorbitol or mannitol, which you get in some fruits and vegetables and may be added as an artificial sweetener to some foods as well. And we found that there's a lot of evidence now to support the use of a low FODMAP diet. What happens with FODMAPs is that they increase small intestinal water in the gut, and this has been very elegantly shown by several different groups. and they also impact the gas production. So you can see here the green fructans is actually increasing the gas production over time, which is represented in this MRI here. You can see where the gas is being produced. So there is lots of mechanistic evidence to support the mechanisms of FODMAPs in increasing water and increasing gas within the small intestine, within the gut. And there have been lots of randomized controlled trials looking at the low FODMAP diet, and this systematic review and meta-analysis shows in this forest plot that you can see that the low FODMAP diet is more beneficial than the control diets. It's very important to also think about comparing the low FODMAP diet to other dietary treatments. And when this systematic review and network meta-analysis came out, it indicated that the low FODMAP diet was actually far more superior to all other dietary management strategies that had been compared to it in the randomized controlled trials that have been done. So the low FODMAP diet's a really important one to be considering. And when we look at the dietary intake in the low FODMAP diet, we can see that the lactose content, so this is some work that we did looking at 2 randomized controlled trials that we did comparing the low FODMAP diet either to a habitual diet or to a sham diet. And you can see at baseline, the patients all had a sort of a reasonable amount of lactose in their diet, around 9 grams per day. And those that followed the low FODMAP diet after 4 weeks, this had reduced down to 4 grams. And in the sham diet and habitual diet, it hadn't really changed. So it's really important to understand that lactose is actually a FODMAP, and it's part of that whole approach. But we also need to be aware that if we follow a low FODMAP diet, it's not just about FODMAP restriction, but it's also about challenging with those high FODMAP foods to find someone's personal tolerance threshold, and then to ensure that they're not actually restricting FODMAPs that they don't need to avoid in their diet. In the long term, we did this study where we looked at patients that had been on a low FODMAP diet for 4 weeks and then followed them up a year later, and found that actually their lactose intake didn't really change over that year period once they'd reintroduced lactose. So perhaps a lot of people with IBS don't need to be restricting lactose. And again, the important thing at the bottom here is that their calcium intakes weren't being impacted in the long term either. So although the low FODMAP diet's restricting lactose in the short term, it's not actually having a negative impact in the long term. So lastly, I want to talk about the prebiotic effect of lactose. And this was a study that was published in the American Journal of Clinical Nutrition by Jan's group. And they wanted to look at whether they could induce adaptation within the colonic microbiota by giving lactose to people with lactose non-persistence. So they took 25 men and women of Asian ethnicity who had reported that they avoided dietary lactose in their diet, and they had a specific genotype, which is most often seen in the Asian community. And they gave them 3 4-week courses of an increasing dose of lactose, and the doses were actually 6, 12, and 24 grams per day. They gave 2 doses per day, so it was 3, 6, and 12 grams in each dose. And they measured the microbiome, the GI function, and the microbial activity. And at the end of the study, they found that the abundance, the alpha diversity of bacteria within the colonic lumen within the gut had not changed. So that was an important finding, that there was no change in the actual abundance, but the beta diversity, which actually shows the variability, was changed. So if you look at before, you can see the orange dots down here, and after, you can see the green dots up here. And if you look at the actual composition, it's the bifidobacteria in purple here that actually increase after the supplementation with lactose. So this is really exciting because it's showing that there is a prebiotic effect of lactose in the colonic microbiota, and you can see that there's an increase in all these different species of bifidobacteria as well over that period of time. In addition, they looked at sort of symptoms and breath tests and found that there wasn't an increase in the breath hydrogen levels. In fact, it actually came down, and there wasn't an increase in symptoms. Most of these people didn't have symptoms at baseline, but they didn't go on to then start developing symptoms. So giving them up to 24 grams of lactose per day didn't actually impact their symptoms, but it actually improved their tolerance by doing it gradually, increasing every 4 weeks by 6 grams. And you can see that their fecal beta galactosidase also increased by more than double as well. So I think this is really exciting. And, you know, if you're increasing the consumption of lactose, you are affecting those beneficial bifidobacteria in the gut. And this is really helpful. It's acting as a dietary fiber, helping to improve the gut microbiome as well. And it's improving the capacity for the gut to metabolize lactose without actually increasing gas production. So it's not going to impact on symptoms, and this group showed that as well. And the lactose consumption up to 24 grams a day is being well tolerated. So this is actually higher than what we were recommending previously. And regular consumption of lactose is probably something that we should be encouraging to help with this sort of beneficial bifidobacteria in the gut. So when should we restrict lactose? So if lactose is a reported problem food, then it may be worth restricting it. It may be worth testing to see if they're getting symptoms during a breath test, but are those breath tests really that reliable because they're giving a very large dose of lactose on an empty gut? Patient choice has to come into it as well. When people do restrict lactose and find that it's beneficial, they may find that they don't want to then reintroduce lactose to their own personal tolerance threshold. And you need to be thinking about that patient choice and their ability to comply. And then perhaps thinking about retesting their tolerance as well. Maybe giving them a dietary challenge would be a useful tool to think about. So I would like to say thank you very much for listening. And just to conclude, lactose is a unique and fascinating carbohydrate that's only found in mammalian milk. Malabsorption is common and present in lactase non-persistence and lactase persistence. The diagnosis of malabsorption, lactose malabsorption, can be challenging. Lactose intolerance is clinically important. We want to manage it well, making sure that we're reducing lactose dairy products to someone's personal tolerance level, not excluding it completely if they want to include some lactose that may have some nutrients that are particularly important. So things like calcium, vitamin D. Mixed meals are important to think about when you're improving tolerance to lactose, and gastric emptying. Transit time may improve tolerance as well. And it's often associated with IBS, and other dietary restrictions may be needed rather than restricting lactose. And think about the prebiotic effects as well. Gradual lactose reintroduction may help with colonic adaptation. So thank you very much for listening, and I look forward to your questions.
Wonderful, Miranda. Thank you very much. Again, if people want to ask questions, please use the Q&A function, and don't forget to like questions you find particularly relevant, interesting, or important. There's one announcement I would like to make, and that's that because of the technical problems that we had at the start of this webinar, we will continue the webinar a little bit longer and finish at around 10 minutes past 3 Central European time. If you cannot stay until the end because you have other obligations, And please know that we will record the full session, and that this recording will be made available to you in the coming days, and it will also be uploaded to the FrieslandCampina Institute website. So let's go to the Q&A section and see what interesting questions came in. So first of all, Miranda, I have here a question about lactose intolerance specifically in Africa. So is it true that it is predominantly found in Africa? And if so, how does the environment impact on lactose intolerance? And specifically, which enzyme is absent and is responsible for lactose intolerance?
Well, I hope I've covered some of this in my talk. So yes, I would say that Africa is somewhere where there is a lot of lactose intolerance, but also lactose malabsorption because of the high level of lactase non-persistence. And I think what's important here is that if you looked at the figure that I presented earlier, there was one particular part of Africa where dairy farming was introduced about 10,000 years ago, where lactose tolerance was actually happening. And this was due to a mutation in the gene enabling people to actually tolerate lactose. So it is the enzyme is lactase that was absent and responsible for the issue. So I hope that's answered that question.
Okay, thank you very much. I think it does. Another question is about the temperature of food. How does that affect lactose intolerance or lactose tolerance?
So it's more that the temperature is affecting transit through the gut. So very hot or very cold might alter the transit through the gut. And it will also depend on what else is being had at the same time. So if you were to just have a very hot drink, it might pass through the gut very quickly. And it really depends on a number of different things. So it's not just about the food temperature, but it's also about what you might have with it as well. So I think we need to consider mixed meals and having drinks on their own in between meals on an empty stomach, and what impact that might be having. So it's worth thinking about, if you want to improve tolerance, to not have really hot or really cold drinks in isolation on their own, and to try and sip them a little bit more rather than to have them really quickly. That might help to improve things.
Yeah, and I think also medication use can affect transit time and affect lactose tolerance and intolerance in that way, right? Yeah,
absolutely. And the other thing is medication. Some medications that might be used for gut symptoms may actually have lactose as a filler as well. So it's definitely worth looking at the excipients on a particular medication that might be used.
Yep. Another question is about the kind of pre or probiotics that can be used for lactose intolerance.
So I would say, following on from Jan's study, lactose itself is a really good prebiotic that can be used to help improve the tolerance of lactose in the long term. So starting at a low level, maybe sort of 3 to 6 grams initially for a few weeks, and then building up to sort of 12 grams spread over the day, and then up to 24 grams. That's a really high level of lactose, in fact, because when we're looking at the levels that we might consume in the diet, normally we're looking at somewhere between about 9 and 12 grams per day. So if someone was tolerating 24 grams of lactose, then that's having a really, it's acting as a prebiotic fiber. In terms of probiotics, so lots of yogurts and lots of specific probiotics may have that ability to improve lactose tolerance as well. So that's another thing to consider. Particularly improving the bifidobacteria within the gut is helpful, because you're not actually increasing the hydrogen production or the gas production, which might be leading to more symptoms as well. So something that's going to improve the bifidobacteria. So maybe bifidobacteria is a good one to be thinking about.
Yep. Another question: would you first try low lactose or low FODMAP with IBS if the cause of the symptoms is not clear?
That's an interesting one, and I would say it all depends on the diet, because depending on what someone's actually eating, they might not be having much lactose in their diet, so a low lactose diet is not going to have much impact. However, they might be drinking loads and loads of milk, having lots of ice cream and lots of high lactose foods, which might mean that a low lactose diet is appropriate.
Mm-hmm. Yeah. Next question. From what age can the breathing test be done?
Gosh, I don't actually. I would imagine we need to think about who could actually take a solution of lactose. I mean, I would say that this is something that we'd probably be doing in adults more so than children. I'm not a pediatric dietitian. I work with adults. I've never heard of people using it in pediatrics, but I could be completely wrong. But I would say that, if you're thinking about trying a low lactose diet in pediatrics, it might be worth thinking about the dietary options, going for a low lactose diet first and seeing if that's impacting the symptoms rather than going for a breath test. I think breath tests can be quite challenging in terms of the interpretation. We don't use breath testing for lactose malabsorption nearly as much as we used to. We actually do the dietary restrictions first rather than going for breath testing, because breath testing is not a normal physiological state when you have that large dose of lactose. And, if you're thinking about trying to do this in someone who's young, are they going to be able to breathe into a tube every 15 minutes after they've had that test? And are they going to, is it sensible to be doing a fast overnight for 10 hours as well beforehand and putting them on a special diet? It's probably much more sensible to think about the dietary sort of gold standard that I talked about, where you would reduce the amount of lactose in the diet for maybe up to 4 weeks to see if you get symptom improvement, and then to challenge with lactose to see if the symptoms come back, and then to identify the personal threshold that would be suitable for that individual.
Yeah, agree. Can lactose intolerance increase when growing older? And what about the percentage of intolerance and malabsorption within geriatric patients?
So as we get older, that lactase persistence will gradually decline in many people. Some people might go on into their later life and not have any problem with lactose at all. And I think a lot of people are like that, particularly in the sort of Northern European area that I was talking about, where lactase persistence is present. So I would say that, you can't be generalist about this. I would say you need to take an individual and try and identify what it is in their diet that might be contributing to their symptoms. If they're getting lots of gut-related symptoms, is it lactose or is it something else that's causing that?
You briefly touched upon a suboptimal bioavailability of calcium and dairy-free alternatives, but do you know if the bioavailability of other micronutrients such as phosphorus, zinc, iron, magnesium can also be affected? This
is what I would call an under-researched area at the moment, and I think we need to do a lot more research in this area. I can't with my hand on my heart say that I can give you the answer to that. So it's an area for research, I would say.
Yeah. I agree. I'm also not aware of studies that really looked into this. Can lactose intolerance cause long-term health issues if untreated?
Not that I'm aware of. I think the issue with lactose intolerance is about the symptom generation, and having symptoms all the time will, in the long term, affect your quality of life, which will impact your mental health. So I guess, your long-term mental health may be problematic if you're continually having signs of intolerance symptoms. So, but not in a physiological way is it going to impact the gut and make you at higher risk of other diseases. But I think probably from a sort of psychological perspective, then yes, but physiologically, I don't think so, no.
No, I think one of the misconceptions is that some people think that lactose intolerance is also an inflammatory disorder, which it is not.
No.
So there is no inflammation going on in the gut epithelium or whatever. So I also think in the long run there are no physiological health issues. Let's see. There is another question that asks if there is any relationship between diabetes and lactose malabsorption.
So my understanding on this, it's not my area, but I do think that there is if you actually use lactose as a prebiotic, I think you can help manage diabetes better, but I don't think lactose malabsorption will have a negative impact on diabetes. You may find that actually having lactose as a prebiotic will help the management of diabetes, but not that it has any negative impact.
Okay, then I have a question in Dutch, and I will translate it. The question is, what is now exactly the cause of lactose intolerance? Can you become lactose intolerant if you don't consume lactose for a longer period of time?
So I think in terms of the lactose production, the majority of the population, their lactose production reduces down over time, particularly during childhood. So say 65% of people are losing that lactase production. And I would say that if you include a little bit of lactose in your diet, your gut microbiota does change and enable that tolerance. So if you're not including lactose in your diet in the long term, you may find that you get intolerance symptoms more easily.
Yeah. Okay, thank you very much. There is a question about the impact of lactose intolerance on the health and well-being of pregnant women in developing countries, so especially as it concerns the pregnancy outcomes. Is there any relationship there, association?
I wasn't really looking at this particular area in my preparation for this talk, particularly in developing countries, but I would say that, dietary guidelines are absolutely key to healthy pregnancies. And I think it's really important to be thinking about dietary diversity and making sure that you're meeting all those nutritional needs of your population, depending on what your local needs are in terms of nutritional concerns. So I would say, in terms of the diet, it's really important to make sure all those nutrients are being met, and however that might be within that local population. So that's key. So following guidelines that are set locally is really important there.
Okay, thank you. And then I think with an eye on the time, the last question. Let me see if I can maximize it. Are there any other possible causes for my symptoms besides lactose intolerance? And I think here the symptoms are gut health problems. I think you already discussed the overlap with IBS. Yeah,
and I think if you're worried, if you're worried about symptoms, go and see your doctor. Have all the sort of the discussions in terms of what your symptoms are, and there will be a series of tests that would be recommended to make sure that you're not some of the symptoms of lactose intolerance can overlap with other disorders, so it's definitely worth getting yourself checked out and making sure that it is down to lactose and not something else, and not just doing it on your own, because you don't want to miss anything if you do it that way.
Yep. Okay, thank you very much, Dr. Lomer, for your presentations and for the answers to our attendees' questions. It was a wonderful session, and every time I hear you talk about lactose, I learn something new, so really appreciate that. I also want to thank our attendees for sharing your time with us, and again, apologies for the difficult start of the webinar. Please do not forget to complete the evaluation form. Let me show you this slide again. So please do not forget to complete the evaluation form to receive a certificate via a link in the Q&A section or by email. Certificates and recording will be made available next week. And for Dutch healthcare professionals, accreditation is in progress with the different organizations. So please have a look at the FrieslandCampina Institute website for updated articles and brochures and tools, also on lactose intolerance. I hope you all enjoyed this webinar. Know that the FrieslandCampina Institute organizes more webinars this year. And with that, I'll say good morning, good afternoon, good evening, good night to all of you. Thank you very much and have a great day.
Thank you. Bye-bye.
Bye-bye.